good evening, everyone, once again. I'm Dr. Cecily Havert at Northern Virginia Family Practice. And tonight we are having our next episode of our town hall. And this evening we are very excited to be welcoming Dr. Eileen West, who will be speaking to us a little bit, or maybe a lot, about menopause. And we're really looking forward to that conversation. Before we get started, I just want to do a little bit of housekeeping here, some information about what to expect for this evening. We also have a fun announcement that we'll be making. I'm going to have Dr. Beauvais make that announcement, but what to expect, the talk this evening will last probably about 30 minutes. And then afterwards, there will be an interactive question and answer session. What we're going to do for the question and answer is there's a little tab at the very bottom that says Q&A. If you can put your questions in there. That would be great. We can then we'll jump on in there and see what we can answer. The chat is also enabled, so feel free to make commentary, if you want to use that. But questions for Dr. West, I'm going to ask that you put those in the Q&A just so we can keep those all together. You don't have to scroll too far. The talk is being recorded this evening, so you can watch it over and over again as many times as you'd like. So just to let you know that is what we're doing this evening. And I'm going to move over to Dr. Beauvais so she can make our announcement.
Sure. Well, I'm happy to have two people to announce today that I'm super excited about. First, I'd like to announce our newest physician, Dr. Maria Castillo-Catoni. Say hi, Maria, so they can see you.
Hi, everyone.
So you're you talk and
right
your face comes on. So Dr. Castillo has been in the area for 9 years. She is a very, very well-respected physician that is beloved, and patients are so excited to continue to see her, but also all the specialists that have seen her make the leap and come to work at NVFP said, "Oh, that's so great. She's so good. She's just terrific." So Cecily and I met Maria a few years ago, and she's talked about opening a concierge practice, several years ago. And we just really loved talking to her and love meeting with her. She grew up in Puerto Rico. She is bilingual. She was educated at the University of Puerto Rico and then did her residency here at VCU. And so we're so excited that she'll be joining NVFP May 2nd. And this is her first public appearance. So welcome. Dr. Castillo goes by Maria Castillo and also by Christy. So if we're interchanging Christy and Maria, that's why. And then I'll move over to introducing Dr. Eileen West. Eileen, say hi so people can see you. You have to talk a little more, I think, so your picture shows up.
Oh, okay. For those
yeah. So Eileen and I were kind of overlapping for almost 8 years together in the same neck of the woods, but we only realized it toward the end. We both went to undergraduate school together at Yale, and then we discovered each other somewhere down the line, both of us at University of Connecticut Medical School, where she was a little bit ahead of me, and I think we met at church actually. So I don't know if you were ever like my senior advisor or anything, but now she's an advisor. So Eileen's been in practice for 20 years, practicing women's medicine all over the country, and most recently running the women's, what was it called? The Women's Health Center, the Comprehensive Women's Health Center at Inova, which sadly shut down because it was an excellent resource. And Eileen went out on her own and is now in a concierge practice with MsMedicine. And actually, I didn't realize Eileen was here practicing in the DC metro area at all until I started reading about MsMedicine, which is a spectacular medical practice with a really, really deep academic roots. And I was just so impressed learning about the very, very powerful academic training of Lisa Larkin, and I know about Eileen's academic training. And so this is a practice that is really, really cutting edge. It is really based on science in guiding women's health decisions. And so we actually send Eileen our tricky things. So when we, Cecily and I'm sure Maria also treats a lot of people in the menopausal area, premenopausal. We do lots of birth control consultations and hormone therapy consultations and bone density treatments. And when it gets tricky, I send it to Eileen. So happy to have you here and happy to hear your talk tonight, and so happy to keep learning from you and collaborating.
Well, thank you for that wonderful introduction. And it's also just really nice to be here and to have a chance to collaborate with you, Dr. Beauvais. I'm so glad that we found each other again.
Me too.
And I appreciate the kind words. And I am very happy to see your patients. I love your notes. You guys write the most beautiful, detailed notes when they come through. It's really lovely to see. So, so happy to help any way I can. So,
well, thanks. So you're going to start this evening with a little education for all of us, and then we'll hopefully let's try to make sure we leave time for Q&A at the end, because I think some of the most fun is hearing the patient's questions and also letting us ask some questions as well.
Sure. All right. So I think this is the point where I need to share my screen, which I will do. Just a moment here. There we go. Okay. So let's talk about menopause. This is one of my absolute favorite topics. So I'm really glad that you're interested in hearing some more about it as well. I don't know how many people are on the call are menopausal women or people who treat menopausal women, but I think there's something to be learned for everybody on the subject. One of the things that I came to discover as I studied this area more and more is how little it's actually really discussed. And I think that it's really important to have an opportunity to discuss the topic and bring it out to the forefront and let people know all the good and the bad, all of the ins and outs, all of the components that we need to know about menopause so that everybody can benefit from it. So without any further ado, I'll go ahead and get started. Let's see. Next slide. Okay. So what I'd like to cover today is I want to go ahead and define menopause for everybody. I'd also like to be able to help you all recognize the symptoms of menopause, understand which treatments can help to manage the menopause transition, and also to address other health issues that are important to consider for women in menopausal age. I love this picture because to me, this is the setting of people gathering, sharing stories, expressing their genuine interest and concern for others in a setting of people that they love and trust. And this is generally the environment, either here or in a doctor's office, tends to be where menopause is discussed. And but I think probably more here in this setting among friends and family, close friends and family. Those are the people that really share some of their menopause adventures. And what we want to do is help to broaden that and open it up so that it's a topic that everybody is comfortable with, familiar with, recognizes signs and symptoms, and is comfortable discussing so that they can improve symptoms as they arise. So menopause is a clinical diagnosis. It's based on history, symptoms, and a person's age. The definition of menopause technically is that there are no menses for 1 year. The average age of menopause has been 51 for millennia, as far as we understand it. The documentation that we have goes back many, many, many centuries. And it's been between 50 and 51 for almost all of that time. Premature menopause is a term that you might hear, and it is defined as experiencing the menopausal transition before age 40. The upper age limit of menopause is somewhere around 57 or 58. It's very unusual to have people who are experiencing regular cycles beyond that point. And perimenopause is the 1 to 2 years prior to the onset of menopause. 25% of people who experience the symptoms, which can last 12 or more years, but average somewhere in the ballpark of 4 years for those who experience symptoms, 25% will have no notable hot flashes, and a very unfortunate few, 2% will continue to have ongoing menopausal symptoms throughout the rest of their lives. The stages of menopause, a woman's life is very frequently defined in 3 clusters groups. They're sort of and when you look back at many, many cultures across time, you see this definition of the maiden, the mother, and then the wise one, the more senior one. And that age group in all of these cultures is really looking at the menstrual cycle. So there's the time when you start menses, but where you haven't fully developed. Then there's the phase where people are in their active reproductive years, and then the time after menses stop. And that transition time into an absence of menopause is also divided into several stages. One is that perimenopause time, which can go on for several years even, prior to the complete cessation of menses. And during that time, our cycles become more erratic, and the beginnings of symptoms happen. Menopause is actually in that very first year without a period. So the definition of full menopause happens after you've gone 1 year without a period. And then postmenopause is all that time once the diagnosis is formal and the situation is clear that no more menses are going to be happening, and then it goes on from there. Here's just the beginning of a list of symptoms. This is a busy slide with lots of information on it, but what you see are any and all of the symptoms that can occur as women experience this menopausal transition. The most common are listed in red on the left-hand side, and we're going to focus in on those as we go through this presentation. Hot flashes, night sweats, irregular periods, loss of libido or sex drive, vaginal dryness, and mood swings. But notice how many other symptoms are there. I hear a lot in my practice about itchy skin, about electrical shock sensations going down the arms or the legs, changes in bladder habits, palpitations and irregular heartbeats, irritability, depression, headaches, weight gain, memory lapses, brain fog, all of those types of symptoms, which are in fact correlated with a change in estrogen status. The number one most bothersome symptom that women have is the hot flashes. We hear the most about hot flashes. Sometimes it's the first symptoms to appear, but not always. And a hot flush is described as a redness and flushing from the neck upward. It's associated with sweating in many cases, but not all. And most of that sweating can be really the torso up. A typical hot flash will last somewhere up to 5 minutes and can be associated with a rapid heart rate. And it also tends to be more common at night. So what causes hot flashes? Actually, this is one of the areas of study that are very recently actually pinned down and defined scientifically. So it's been the big news the last year or so in menopause circles, is understanding some of the pathophysiology behind hot flashes. And they're thought to be related to an increased sensitization or sensitivity to slight body temperature changes and by the brain's hypothalamus. And that the hypothalamus is the temperature regulator, and it controls heat production and heat loss. So it's sort of an exaggerated response to a little bit of cooling or a little bit of heating up. So the body just overreacts to a slight temperature change and causes this hot flash in an attempt to cool down. So we know that hot flashes are definitely triggered by a decline at circulating estrogen levels in the bloodstream. And we know that hot flashes can be more pronounced in those who smoke, those who are obese, and those who don't have a healthy diet pattern. Here's something that we discovered that was a study result that was published in 2019, the SWAN study, which is the study of women's health across the nation. And it discovered that women who experience frequent or persistent hot flashes may also be more likely than women who don't to experience a heart attack or stroke. So for the first time, a link was made between the possibility that hot flashes could be an indicator of cardiovascular risk in women. And more frequent is defined as 6 or more days in the past 2 weeks. And the description of persistent hot flashes were when the topic came up repeatedly in the doctor's office. And we've learned recently, the last 10 years have taught us quite a bit about cardiovascular risk in women and how there is a hormonal component to cardiovascular risk. For example, we now know as primary care physicians that it's very important to take a gynecologic and an obstetrical history in a woman, because women who go through preeclampsia, which is a sudden rise in blood pressure and a problem with filtering proteins through the kidneys, which can occur right before delivery. Those who experience preeclampsia have a 4 to 5-fold increased risk of cardiovascular disease 25 years later. We've also come to understand that other conditions that women experience that are related to ovarian function, such as polycystic ovary syndrome and endometriosis, are people who have those diagnoses are at increased risk for cardiovascular disease as well. So this field is growing, and it's of tremendous interest, as we know that, we understand now that 1 in 3 women will die of some form of heart disease.
Eileen, can I ask a quick question?
Sure.
Just to go back to that slide, when you were comparing the hot flashes, do you know if they controlled for the use of hormones? Because it seems like people who have hot flashes are more likely to use hormones than people who are not. I don't know if that correlated at all to any of the study results.
That's a really good question. And so far, what we understand about hormones, there is actually early in the process of menopause, hormone use can actually have vascular benefit. It increases endothelial tissue, smooth muscle relaxation, and it is associated with, actually a decreased incidence or slowed accumulation of plaque in the blood vessels. But we don't know for certain. We use really primarily to assess, looking at an age-related effect. So the older someone becomes, the more likely they are to have cardiovascular risk factors, which makes them much less of a good candidate for hormone replacement. Mm-hmm. So, but as far as whether they controlled for hormone use, I'd have to go in and look at the study in a little more detail and see for sure. exactly what was determined. My guess is that they outlined that fairly clearly, and they talked about it, and they probably broke it down by category as far as number of years of use, some no use, some use, and significant use.
Mhm.
So.
Thank you.
Mm-hmm. The next topic that we hear quite a bit about in a menopause practice is vaginal dryness and frequent urinary tract infection. There's been a lot of interest in this subject. Well, there's always been a lot of interest in it, but now what we're finding is that there's increasing evidence to support the new definition of genitourinary syndrome of menopause, or GSM. And the things that are most important to recognize about it are, first of all, what are the symptoms? Dryness in the vaginal area, discomfort or pain with intercourse, which is a huge problem for many, many women. Urinary urgency, painful urination, and recurrent urinary tract infections. So it's been really interesting to watch the urologists take up the charge on this particular topic, and to really push for studies that show, which have now shown multiple studies, that topical vaginal estrogen is very effective at reducing the symptoms of genitourinary syndrome of menopause, and also extremely safe. There are now, based on repeated studies, very few people for whom that treatment would not be appropriate. So what you're hearing now is, a lot of discussion and a lot of interest in using topical vaginal therapy. And I have taken breast cancer survivors and talked with the oncologist. The oncologists, many are now on board with the use of topical vaginal estrogen as well for the genitourinary syndrome of menopause. And the argument is, you're going to allow a woman to experience and potentially die from sepsis because you are trying to save a very, very low relative risk of a complication. It's really, there's virtually no good reason not to consider use of it in patients who are having problems. There are some who would even go as far to say that every woman over the age of 50 should be considering postmenopausal vaginal estrogen cream to keep the tissues, supple and lubricated and functioning in a more normal manner. It helps with bladder function, with bowel function, with vaginal effects as well. Another area that is problematic for people are irregular periods as they head into the menopause approach. 90% of women will experience 4 to 8 years of menstrual cycle changes. So, and a typical pattern might be that the length of from one cycle to the next will gradually lengthen. So whereas you might have been every 28 or 29 days like clockwork for years, might start to last 30, 31, 32 days instead, but still be fairly regular. And another thing is that the length of the actual menses time shortens. So what used to be maybe a 4 or 5 day experience often will shorten down to 2 or 3 days for people. Conversely, the cycles can also become wildly erratic and can be very heavy. And those heavy cycles are, and frequently what you'll see is a skip pattern where you may not actually be ovulating with every cycle. And so you might have a light period and maybe another light period. And then if you ovulate in the third cycle, you might end up having a significantly heavier period that's balancing out the two very light ones. So it can be a real problem with unpredictability. A lot of women just find that really difficult to deal with. So it's important to consider other variables besides just my hormones are changing when people present with irregular periods. So these are some of the things we really want to look for, things that can go wrong in the reproductive tract, or hormonal problems, thyroid issues are a good example, endometrial problems, endometrial thickening, or endometrial cancer. So lots of other things can cause irregular periods. It's important to get hooked up for it, but it's not at all unusual to see at the time of menopause. Another topic that comes up frequently is the loss of libido, or just reduced sex drive, an interest, desire in sex. And sometimes this can be due to dry vaginal tissues, which result in painful or uncomfortable sex. And sometimes it's just a complete lack of interest. And we know that to be partially hormonally induced as well. So I don't know about you. Do you all ever hear people worry about insomnia? Anybody? Hands raised. I think increases in anxiety, increases in waking in the middle of the night, hot flashes causing sleep disturbances, not being able to fall back to sleep, feeling wide awake and alert in the middle of the night are all symptoms that can come about as a result of hormone fluctuations at the time of menopause. This is one of my favorites. I love Dory saying, better send myself an email so I don't forget. Oh, look, I've got an email. And it just points to the fact that it's really easy to be somewhat more distractible and more forgetful as women go through this menopause transition. We know that estrogen plays a role in attention, mood, language, and memory. And it's very common to experience lapses in memory during the early and middle stages of menopause. So, and some of that is, is it the insomnia that's causing poorer attention? But there is a decline in working memory, or the ability to assimilate and manipulate new information. People just don't perform as well as usual when they're going through this menopause transition. The good news is it doesn't mean it's permanent. It seems to be related to the fluctuation in hormone status. I like to remind patients that, if the memories if the information isn't getting in the first place, it's going to be very difficult to hang on to it and file it and store it away in long-term memory. And we live in a very distractible culture. We all have computers in our pockets that remind us incessantly of other things. And so it can be hard to stay focused. We all like to multitask. And, there are good recent studies that support this concept that, multitasking, we're not as good at it as we think we are. We're just paying shorter amounts of attention to two things instead of truly focusing on the thing at hand.
Eileen, could you do a quick overview on the, the last couple slides of symptoms? Mm-hmm. How many of those are things that are modifiable with treatment?
I would say that there is genuinely some improvement with various different treatment strategies. There is some treatment available for each of these issues. They can be modified, they can be adjusted. The question is, what treatment strategy would you like to pick? And there are the treatment strategies range from lifestyle modification all the way up to hormone replacement. So we've got a wide range of options, lots of non-hormonal hormonal treatments as well as hormonal treatments. So I think that there is a very good indication that many of these things will improve with treatment. They may not be at 100% functioning immediately, but there is definitely a chance for some improvement. Mood swings are another topic that come up frequently. It's defined as a sudden or intense change in emotional state, and people can quickly switch from feeling happy and upbeat to being sad, irritable, or angry. And it's a reactive response, and it is very common. And the extent of it, when it really becomes important, is if it's really interfering in one's ability to function and to do the things that you normally do, or having a significant negative impact on relationships. It's also really important to do a little more investigating when people describe mood swings, because you don't want to miss an underlying depression as the cause of some of the symptoms. This slide, I think, is this is, again, it just reminds us that, here's a woman and presumably a partner sitting on the couch, or someone who lives in the house with them, saying hot flash, and you have no idea how freaky it is to live with menopause. And he says, oh, don't I? And it's just a good reminder that women are not the only ones who go through this. So for as far as treatments go, experts really recommend at this point that hormone therapy, MHT is the new description for menopausal hormone therapy. MHT is the first line of treatment for symptoms of menopause. And in a 2017 North American Menopause Society position statement, it said hormone therapy remains the most effective treatment for vasomotor symptoms and the genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. I think we can take a deep dive on the Women's Health Initiative at some point. I probably will save it for questions just because it's pretty involved, but if anyone is interested in that. But suffice it to say that 20 years after the Women's Health Initiative, we really have come to understand that there were some flaws in how that study was performed and how the data was interpreted, and that it doesn't necessarily, it generally exaggerated risk, a relative risk for the use of hormone therapy. And yet, because it was so widely broadcast and it was announced very publicly that hormone therapy might cause breast cancer, that 75% of all women stopped taking their hormones immediately at the time that the study came out. And we're now 20 years later, we have evolved. We have come to recognize that the single agents that were used, we now have other forms of hormone replacement, which may not confer the same risk. We also understand that the data was extrapolated from an older group generally to apply to a younger group, and that women who might be at high risk, were actually women who experienced heavy hot flashes, were actually discouraged from enrolling in the trial, and the average age of enrollment was 63, which is a full 12 to 14 years past the onset of menopause for many women. So a little problematic, but it's the largest study to date, and we work with it, and we live with it daily. So another thing that has come out in this newer update is that the duration of menopause therapy can be individualized, and that there is no exact, precise time when hormones have to be stopped. It was generally believed that hormone use was safe up to around age 60, but then at that point it should be stopped. But we really are starting to move away from that model now. Research is coming out with other forms of estrogen and progesterone, and the risk is really being looked at in more detail. And if a woman is on a low dose of hormone therapy and is doing well on it, there is no clear indication. It is not a mandatory cutoff to stop. You really reassess each year, take a look at the woman's risk factors, and decide what the risks are compared to the benefits.
Eileen, with the hormone replacement therapy, maybe you're going to get to it. I mean, the indications for that are mostly when I consider it or have discussions with my patients is, people who are really having horrible vasomotor symptoms is one thing. And then also, the vaginal symptoms too are another. And then with the vaginal symptoms, do you consider more of a topical or like, a topical form, or do you actually use the oral form or the patch transdermal forms to treat the vaginal symptoms too?
There are times when it makes sense to use them in conjunction, but the topical treatment is really the first line of treatment for GSM.
For the vaginal symptoms, correct?
Yes.
And
If
the hot flashes,
yeah, and then the hot flashes and some of the other things that we look at now can be, I would argue that the hormones are really beneficial in relieving some of these other symptoms as well. And that's what a lot of the sub-studies and breakdowns of the WHI have looked at since the initial study was published. But in follow-up, there's really data to support better bone strength and a very low relative risk with the things that they were initially concerned about. So it's important to remember that hormone therapy the goal is always to relieve symptoms. We don't do a lot of checking of hormone levels for women once you get through sort of an initial understanding of where people are. You really don't need to keep checking and repeating hormone levels, which I know has become increasingly popular in practices around us. But the objective is to relieve symptoms. We're not trying to treat to a specific number. We're not trying to return the body to where it was at age 25. We're trying to ease some of the symptoms that people experience as the estrogen levels decline. And also it's important to remember that we aren't really using it for full-on prevention of chronic disease. With one exception, there is that group of women who experience early menopause, who it is now pretty widely recognized that almost every woman who goes through menopause before age 50 should be encouraged to get to the natural age of menopause with protective hormones on board. And the reason for that is that we know now that cardiovascular risk significantly increases, bone risk significantly increases when the period of menopause is prolonged, when it starts too soon. So it's widely encouraged and urged, and it can be, sometimes it takes some educating for our patients to understand why they might benefit from hormone therapy when they're 38 and go through menopause surgically or otherwise. So, but that group, we are actually working, and there's good data to support that we're preventing chronic disease by treating those women under age 50 to get them to the natural age of menopause. I talked a little bit about the Women's Health Initiative. And again, even in the WHI, it was a solution for symptomatic menopausal women under the age of 60 who were within 10 years of menopause at the time of initiation of the hormone. And for most, the benefits far outweigh the risks. So despite all of this, there's still a very strong bias against hormone use in our culture. And the data really doesn't support dramatic harm. It just doesn't. So, and I can talk a little bit about relative risk. For example, when you look at the relative risk of something like being BRCA1 or BRCA2 positive at the far end of the scale, as far as the highest possible risk for breast cancer, that relative risk is 600. When you look at a relative risk of increased breast density on mammogram, that relative risk compared to an average person for the development of breast cancer is 6. The relative risk for postmenopausal obesity and for alcohol, excessive alcohol use defined as more than 3 glasses of alcoholic beverage per week is 1.2 to 1.3 relative risk. And estrogen, menopausal hormone therapy greater than 5 years of use, the relative risk is 1.3. So it's very far down the spectrum. as far as
That's a
there
great
is.
number. I so appreciate your actual data on that, because just realizing that that risk is very similar to having 3 beers a week is not how I understood it before, and it's very easy to relate and describe to people.
Good. I'm glad that helps. All right. There are lots of different forms of hormone use, and often the selection of the form of hormone is personal preference for people. You can take pills, you can wear patches, there are vaginal rings, there's cream that rubs in, or gels. And all of these options are available. The question is there any preference for one over the other? And the answer is it depends. It depends on the woman's specific situation. It depends on her any other risk factors that she might have. You know, those are, we'll get to treatment shortly, but there are, I have some slight preferences in general for my patients, but there are a wide range of choices. So. Now, there are some people for whom systemic, yeah.
I just want to give you a time check.
Oh, okay, how are we doing?
Yeah, it's 7:45.
Oh my goodness. Okay.
Yeah, and I think we do need to hear all of the everythings, but
yeah.
I don't know how many more slides you have, so I just wanted.
Yeah, no, thank you I didn't realize I was when I go off on tangents, it takes extra time. So I will, yeah, I can stop this at any point. There are a group of women for whom estrogen therapy is probably not a good idea. And I just want to make sure people understand who those people are. Those who have unexplained vaginal bleeding, those who have a history of a cardiovascular event, such as a stroke or a heart attack, those who have a history of a blood clot, those who have a history of breast or endometrial cancer should not be taking systemic hormones. However, topical vaginal treatments are acceptable. And anyone with severe liver disease, because estrogen is metabolized by the liver, it's probably not a good idea to take oral systemic hormones.
Does that count for transdermal too, or the patches?
Now, the transdermal, it has a relatively lower risk, we believe, as far as blood clots are concerned. There is some good emerging data that supports that topical estrogen use really does not increase blood clotting risks to the same extent. And those with more minor genetic variants that are put them at risk for blood clots actually may do fine on hormone replacement. So
that's usually my kind of go-to is the transdermal, and maybe we can talk a little bit in the upcoming discussion, but that's usually my kind of first line, just to avoid some of the first pass effect through the liver if I'm going to consider it. But obviously it depends.
And I would say that's the case for me as well. And with or without the oral progesterone, depending on whether they have a uterus.
If you get uterus, yeah.
And the progestins have really improved too. Now we're using micronized progesterone much more, which is generally safer overall. So then there are some people for whom you want to think about what the overall risk picture look like. And a lot of those have to do with with increased cardiovascular risk associated with some of the conditions on the list there. So I have a lot of slides that talk about different types of therapies, and maybe I'm just going to give you in a nutshell. There are non-medication related solutions, things like stopping smoking, exercising regularly, maintaining a normal body weight has a big impact on menopausal symptoms, avoiding excessive alcohol and caffeine. And then the added sugars are the problem in the diet, and the processed foods. If we can reduce the added sugars and processed foods and really up intake of fruits and vegetables, it makes a huge difference for how people feel. It also happens to coincide with what is considered a heart healthy diet. So there are external things that you can use to help stay cool during hot flashes. There are mind-body practices which can be helpful. And these can be very well developed. It's really, it's just good overall for relaxation and focus and calming. There are things that you can do to reduce insomnia. This list may be familiar to many, and I'd be happy to elaborate in the questions if people have more questions about that. So, and generally the same rules apply for managing memory changes, except keep active, keep your brain active, you know, take up the crossword in the New York Times and Wordle. I have some information here about supplements if anybody's interested in those. Unfortunately, the benefits of supplements are really no better than placebo in the vast majority of cases. The one point I'd like to make about supplements is you don't need to make expensive urine. And secondly, that if you're going to take a supplement, look for the USP seal on the supplement bottle to indicate that it has been, they've had good quality control in producing the supplement. So, and then there are other medication options available if hormone therapy just is not going to work in a specific circumstance. And we can elaborate some more on these if people have questions about them. Some of them are antidepressants, some of them are blood pressure medications. Some of them are a class of medicine called a selective estrogen receptor modifier, and others are actually anti-seizure medicines like gabapentin. And so I think I'm going to hold there. I'm going to fast forward and just end on the last slide. These are just some issues. Breast cancer risk assessment, very, very important. Now they're recommending it should be done by age 30. And then making sure that you're taking action to preserve bone health, evaluating for colon cancer, and then also addressing a positive HPV test at any point in a woman's past. Very important for overall good health. So these are my three daughters, and I hope that all of this information that we're gleaning and learning over time will help them when it's their turn to go through menopause. Thank you very much. That's all I've got.
Thank you. Thank you so much, Eileen. Yeah, go ahead, Natasha.
Do you want me to go through some of the Q&As?
Yeah. I think we'll go ahead and go through some of the Q&As.
I can stop screen sharing. Let me.
Okay. So question, I think there's a question about basically the length of time that perimenopause takes. And also, I think you had mentioned something about late stage perimenopause. And I'm not sure if you mentioned that. Is there, and what does that exactly mean? And this person's asking, what should I expect? Specifically late stage perimenopause apparently is of some concern.
Yeah, that's interesting. I mean, I think late stage perimenopause typically, it is a gradual process. People really, it can start up to 4 or 5 years prior to the cessation of menses. And late stage perimenopause is really when things become the most erratic and the most notable. And often that's when some of the most intense symptoms are taking place. Because as you think about it, the hormone level swings, your hormone level, your ovaries are petering out. And as you slow down in hormone production, there's a big push, which can cause a surge of estrogen, progesterone to even higher levels than baseline. So that's where you get the swings. What can I do about loss of libido? That's an excellent question. There are actually lots of strategies. Libido is a very multifactorial process. Libido is, there are so many different variables that go into what wakes a person up with sexual interest. It has to do with the nature of the relationship. It has to do with the environment around you. It has to do with your own degree of relaxation and how rested you are. And then, there are treatments available, and I think it's important to tackle it from all angles. There are wonderful counselors, sex therapists who can talk to individuals and couples. There are ways to address any underlying medical diagnoses, which should be done to make sure that there isn't an organic cause for the loss of libido. And then if it turns out that hyposexual disorder is the diagnosis, we actually do have some treatments available to us in the form of injectable solutions and also pills, as well as support with a topical cream like a testosterone cream. So there are strategies. If you are having issues with this, it's a really good idea to talk to somebody about it. See if you can get some help.
What are the pills that I know that for premenopausal women, there's a new, what is it, the Addie pill?
Addie,
yeah.
yes.
And I'm not
Addie
sure if
is
that's
the-
used in, I'm not sure if that's used in postmenopausal women, but when you're talking about pills, what are those?
Well, I'm thinking of there's Addie. The injectable is a medication called Vyleesi, which works as a dopamine agonist, and it's an injectable solution that the effect will linger for about 24 hours, and it really sort of allows some disinhibition and stimulates the body to be interested in that. And I think the interesting thing about it, when I first learned about these medicines, I was also very reluctant to consider using them in perimenopausal or even postmenopausal women. But there is actually safety data from other countries going all the way up to age 60 and beyond. A lot of the sexual medicine people in the circles that I travel in have no qualms giving it to a 60-year-old woman. Because the risk is actually very low. So, but the guidelines are pretty stringent, but there are many people using these medications off label with no ill effect.
Okay. So. And there's the next question. An earlier slide said disturbing memory lapses in quotations were a possible symptom of menopause. What would disturbing entail?
That's a very good question. And I think of it to mean it's disturbing to the individual. It's bothersome, it worries them, and it makes them think that there's something really wrong in their mental capacity. And, there will be some individuals who are developing early dementia. Dementia it's a different process. And it's important to take a look for it. You can do cognitive, neurocognitive assessments, and which are interesting to have at baseline, but can be very informative if you see very specific deficits that can tie it to an early dementia. I have lots of people come in who are absolutely convinced that because their 90-year-old dad died of dementia, that they're going to get it too. And that the fact that they can't remember the names of things sometimes when they're 60 means they're going to get the same dementia. And it really doesn't necessarily work that way. I think, disturbing means just a lapse in recognition, and it's often for smaller things, but they can be very meaningful. I have women going through this menopause transition who are literally like, if it's not on my calendar, it doesn't happen. Because somebody can talk to them all day about it, but they won't remember unless it's written down and they have a reminder later. So,
and a lot of those people are suffering with multiple symptoms at the same time. So like if someone comes in and they can't sleep and they're having memory lapses and they're having hot flashes, then we don't start with, let me fix your memory. We say like, well, it's really hard to function when we can't sleep. So let's figure out what it was going to take to help you sleep, and let's figure out how to help those hot flashes not be so constantly interrupting your day, not just your night. And then, okay, then are you also depressed? Do you also have other reasons to be ADD, for example, which is still present in people that are going through menopausal symptoms. So we don't want to hang our hats all on hormones and use that as the only answer, because there's so many things to consider.
It's like peeling back an onion, and and everything sort of interacts with with other symptoms, the insomnia, so it is, there's a lot of peeling away and trying to figure out what exactly is going on.
Sleep apnea, very common, very undiagnosed. Something like 60% of heart attacks that occur between midnight and 6 a.m. are a direct result of sleep apnea. So lots and lots of issues and problems. You're right. I love that onion analogy. It really makes a lot of sense.
Yeah,
it really is what it is.
It's
repeatedly try one thing, see what happens. Take a look. What's the next option? What's the possibility in another realm that could be causing this?
Yeah, and it's usually one thing kind of affects the other. And then moving on, since we're getting, oh my goodness, we're getting low on time here. So what does the age of menarche affect the age of menopause? Is there any correlation with that?
That's a really good question. Not necessarily. The biggest predictor for the age of menopause is the age that your mother went through menopause.
Yeah. And then if a woman has a hormonal IUD, and assuming that they, not having their periods, how do you know when menopause may begin or if it already has? I guess you just don't, you don't have the period telling you that things are going to be wrong.
And I would say, how is it most relevant? It's relevant if you're experiencing other symptoms. Right. And if you really want to know, it's possible to check a hormone level, but really, what is that going to do as far as management of your care? Is how important is it really to know, okay, now I am starting menopause? Some people really want to know, but really the key is, how do they feel?
A few more quick questions here. Asking about migraines. Can you explain why migraines with aura would require caution for hormone therapy? And I guess that's for birth control pills too. You can kind of lump those two things together.
More so with birth control pills, honestly, than with postmenopausal hormone therapy. And it has to do with the vascular component, that we now believe that women who experience migraines are at greater risk of cardiovascular disease. I guess it's true for any gender, but we know that migraines are influenced by hormone status. When there's a big surge and then a drop in estrogen, that's oftentimes, it can be a trigger for migraines. There are many other triggers as well, but that's one of them. And you just want to be a little more cautious because of the cardiovascular risk. You just have to weigh the equation. There are many people who will still prescribe menopausal hormone therapy to migraine sufferers, and that is because the dose is so much lower than that of a birth control pill. It's really a fraction of the dose of a birth control pill.
Let's see. Frozen shoulder. Is a frozen shoulder an indicator or symptom of premenopause or menopause? I don't think I've heard that before. I mean, I've heard muscle aches and pains and cramps and loss of flexibility, but true frozen shoulder.
Joint pain in general, frequent.
Yeah.
I'm not sure about specific frozen shoulder. I'll have to get back to you on that one.
That one, I haven't heard that one yet either, but that's a good question. And questions just more about, I think it's similar, IUD on continuous oral contraception, not getting normal, or maybe you are getting periods, but they're kind of more withdrawal bleed, first sign of menopause. I mean, that's just sort of hot flashes and insomnia and everything else that doesn't necessarily relate to your cycle. No, can you lose your cycle altogether if you're still on birth control pills and you're cycling?
You mean, can you intentionally go right through your cycle?
Yeah, I mean, probably can your cycle. I mean, I'm assuming what I've seen also is that people who should be having their period suddenly just stop having their period even during the withdrawal time.
Yeah, well, I mean, continuous OCP use is very commonly done and generally considered safe and effective. I mean, you can control when you have your period, but I would say that typically what we'll do in perimenopausal women who are still sometimes getting a period, we can put them on a continuous birth control pill, but at some point we're going to need to make the transition to the lower dose of estrogen treatment. Yeah. So I'll do sometimes cyclic treatment for people who, when they find that they get on their period, that's when their hot flashes are bad, then you can, or when they're on the pill and they're having a monthly cycle, that's the time you can cover with a little bit of hormone replacement, or you can switch to a cyclic a continuous estrogen with cyclic progesterone. So every 2 or 3 months, you schedule a progesterone withdrawal bleed.
Interesting. Questions about bone density. The person basically 49, soon to be 50. They have insomnia, no libido, concerned about bone density and cardiovascular issues. What treatment do you recommend? I mean, that's a very specific question. That might be.
With probably
maybe your
a
next
little more
consult.
detailed discussion.
No, very specific. Yeah.
Yeah, I mean, I would say if you are considered relatively low risk and you're interested in some sort of hormone supplementation, then there are options available, up to the natural age of menopause and a little beyond. You can use a low dose birth control pill, or you can, if you've stopped cycling, then you can think about postmenopausal hormone replacement. So.
Let's see here. So
There was a
I don't know how many more.
question about your-
Natasha, what do you think? How many more should we do? It's what, 5 after.
Oh
We
yeah,
got-
well maybe just 2 more.
2 more questions. Okay.
There was one question about your favorite menopausal hormone treatment in a woman with an intact uterus.
We touched on that a little bit, didn't we?
Yeah.
Dr. Havert and I are in agreement on this one. They're really, for me, I really very frequently, my go-to is some sort of an estradiol patch or a cream. The creams tend to be really expensive. That's the downside to the creams. The patches are available in generic form. And I've just learned now that the once a week patch has come out in generic and is actually cheaper than the twice a week one. So that's a good thing to look out for. But remember, if they have an intact uterus, then it's very important to also do the progesterone component. And that can either be, a Mirena IUD, which is progesterone coated IUD of one form or another, can solve the puzzle, or you can use a daily micronized progesterone as well, or you can do the cyclic with the withdrawal bleed. Some people like that, they're comfortable with that and they want that. So
I did not know that trick. You can use a Mirena IUD for postmenopausal HRT progesterone delivery. Eileen, you're teaching me something every time I talk to you.
Yeah, it's an off-label use. Truthfully. And so that's one thing when you're working in an area where the data is, some data is there and some data is missing. And, getting women's health studies funded through the FDA can be very, and processed and approved through the FDA is a very time-consuming and very financially straining process. And honestly, there's a lot of times it's overlooked. It's just much harder to get these studies done and completed and passed, and the FDA authorization for things. So I have over time learned to live in a little bit of the gray zone. And that's one area that I actually feel very comfortable with, because we know that progestin coating is exactly where it's supposed to be.
Yeah. Cecily, I feel like that's a really nice time to wrap up. Like, are you okay to?
Yeah. I mean, there's a few more questions, and maybe we can even try to get Dr. West to answer some of these questions, and we can sort of post them on our notes. We're going to have this talk. It is being recorded, and what we're going to do is we'll have it posted on our website, so you can go there and watch it over and over. And then maybe in some of the notes, we can answer some of the additional questions that came through. We'll sort of make note of those. So that would be great. And then there's a question about whether or not your slides are going to be available, Dr. West. Do you think, would you be able to make those available also to our patients? Okay, so we'll be able to do that.
That's okay with me.
Great. Yeah. So anyway, it seems like there's always just so many things to talk about, and it's always at the end of the discussion when all the questions start to come out. So
Dr. Beauvais, I just want to highlight that your knowledge is different than ours, and it takes an extra set of training and years of thought and evening conferences that you're going to every week. And I so deeply respect your practice because of its sub-focus, it has tremendous depth. And so I'm really, really grateful that when I have something tricky and person who's very symptomatic, but they have a hypercoagulable state, but maybe it's not that hypercoagulable. And, something really tricky that's not just cut and dried. It doesn't fit into one of these absolute categories, that I can, consult with you and you have an answer that's based on data, and you send me a study that talks about why. And I think, all of MsMedicine, I think, has that focus of, this is a group of people for whom their medical management totally, you can hear my dog in the background, sorry. Medical management totally changes how they feel, and it also really changes their health outcomes. And it's very not sexy to treat, because it isn't a heart attack that's happening today. It's a heart attack that you're preventing long-term, or it's a bone fracture that you're preventing 20 years from now. And so I think it's been very under-noticed in medicine. And so, you and hopefully everyone else who's doing MsMedicine is really, really providing a service that's not only needed among patients, but other doctors need your help too.
It's such a kind thing to say. Thank you. And we love it. We've come together because of this passion and interest in knowing these things. Every time I read something new, I'm thinking about my mom or my sister or my best friend, and I'm wondering, how can I make their life better? And the information is there. You have to search for it and continue to circle back around to the things that are unclear initially. So it's, that's why we all chose this profession, isn't it? Because you go to bed at night having learned something you didn't know when you woke up in the morning.
Right.
It's,
lifelong learners.
Lifelong learners, for sure.
That's the way. Yeah. And that's one reason why we continue having these town halls too, because they're very informative, not only for our attendees and our patients, but I feel like I learned so much. So, once again, I know Dr. Beauvais, Natasha was, thank you for being here, but also thank you so much. I did learn a ton, and looking forward to future collaborations.
Yes. Well, and next time I won't talk for so long. So
that's okay. That's okay. There's a lot to talk about. Maybe we'll do menopause part 2. So we'll bring you back for the second part. And so speaking of future town halls, Wednesday, May 18th at 7 p.m. is going to be our next town hall. And when Dr. West, when Eileen was talking about memory lapses and what's normal, what's abnormal, and I can't remember this word, or where did I put my keys? So the discussion we're going to be having is actually with a neurologist about memory loss and memory loss and dementia, which I also like to call when to worry when you keep misplacing your keys. What's normal, what's not. So Dr. Natalia Kalo will be joining us for this very, very informative discussion. And I'm looking forward to learning a lot with that one as well. Last but not least, I don't know if anybody or everybody has heard, but Natasha and I have launched a new podcast. So finally, we've been talking about this for over a year. This is a new podcast called Living, Breathing Medicine. And we've just dropped our first episode. We'll be dropping those about every 2 weeks. The next one will be coming out this coming Friday. Like I said, it's Living, Breathing Medicine. You can find us on Spotify, Apple Podcasts, or wherever you listen. You can also get a link to the podcast through our website on www.nvafamilypractice.com. So anyway, I'll just throw that little plug in there. But once again, wonderful night, learned a lot. Can't wait to continue talking and look forward to seeing everybody at our next town hall. Thank you so much for joining us. Good night.
Thank you.
Thanks, Dr. West.